It's a pleasure to have everyone here. And as I said, I welcome your questions at the end, or you can email me privately, and I'm always happy to reply to questions as well. This is one of my areas of expertise, if not my passion, hairline lowering surgery. I've been doing these for over 25 years. I first learned it when I was doing my fellowship with Dr. Sheldon Kabaka. Shelly retired several years ago. In fact, I had a chance to visit him several years ago, right before his retirement, to learn his latest techniques for hairline lowering surgery. I presented at a lot of meetings, my technique. What I started doing 25 years ago, the techniques obviously have evolved, but the concept behind hairline lowering surgery is a single stage procedure to basically take the overly high hairline and lower it. I'm going to present a lecture that I presented in Manchester, England, a year ago to it was a FUE Europe, which is a Follicular Unit Extraction meeting held in Europe every year. But I was invited actually to teach my approach on hairline lowering surgery, but also compare it to hairline lowering with transplants, which is another very effective technique, and it has its indications as well. So let me go ahead. I'm going to share with you my lecture. I'm going to go ahead and moderate and narrate it rather. So here it is. And hang on a second, slideshow. So as I said, this was a presentation that I made in Manchester a little under a year ago on the surgical hairline advancement for reduction surgery, but also comparing it to hairline lowering surgery. I have no conflicts of interest. My only interest is in being able to do these procedures and providing the best results for my patients. Lots of reasons. This is primarily oriented towards women, but I'm going to show you some examples of men. The majority of, and for reasons that will soon become apparent, you'll see why the majority of the patients I perform these on are in women. But anyway, so we look at the high female hairline. The most common etiology is congenital lifetime. The second most common, which is right up here, but then lower down, the second most common etiology for high female hairline is female pattern hair loss. It precedes. The reason why I have that in red is those that are in red are definitely not candidates for the hairline lowering surgery. Those are on the top, the congenital and the male pattern baldness in the transgender male to female patient, because when a male individual is undergoing gender reassignment into a female, typically the effects of testosterone have been able to take effect and the hairline's been raised. However, once the transition is done, whether transitioning is done with either genital reassignment surgery or with medicine, they're not going to lose any more hair. So basically they have a stable hairline. Patients that have suffered from traction alopecia and or frontal fibrosing alopecia, which is a form of scarring, can sometimes be candidates for the hairline lowering surgery, also called the SHA, or surgical hairline advancement. And then, as I said, patients that have had female pattern hair loss with progressive hair loss, or male pattern hair loss with progressive hair loss, as well as those that have had a prior brow lift, are generally not candidates for the hairline lowering surgery. They're better candidates for transplants. So anyway, the two techniques are hair grafting with follicular unit grafts. The other one is surgical hairline advancement forehead reduction procedure. They're two effective techniques that each have their own advantages, and etc. So let's look at some examples of hair grafting. And you can see this is a nice example of a before and after achieved with a single procedure. Hairline grafting, each graft is placed consists of 1, 2, or 3 hairs, and I'm able to nicely round out hairlines. This was a single procedure of around 2,200 grafts. You can see another procedure, particularly for rounding out the hairline. Grafting or transplants is going to be a more effective technique. The hairs are usually obtained by the FUE approach, which is basically the grafts are removed one at a time from the back without making an incision, and then they're placed into here. So it's a demanding procedure. A procedure like this of around 1,700 grafts takes around 6 to 7 hours. These procedures can take as long as 10 hours, 12 hours, with not just me, but assisted by at least 3 to 4 of my assistants, helping me with the harvesting or the obtaining of the grafts from the back, and then filling the recipient sites into the grafts into the recipient sites that I've made. That's made with very tiny blades designed to be aesthetic, and you can see how nice and natural this looks. So hair grafting, the reasons why we generally do hair grafting or transplants is for patients with frontal hairline thinning. Got a lot of thinning, it's not really ideal for lowering. They have an unstable hair loss or progressive hair loss. If they have low scalp mobility, generally you're not going to want to do hairline lowering surgery because you won't be able to move the hairline very far forward. If they've had prior scalp surgery, not transplants, but certain surgeries that could have interfered with the blood supply, such as a coronal brow lift, that's a contraindication. If they have posterior hair growth as opposed to anterior hair growth erection, that's not an absolute indication for doing grafting, but generally has to be considered that you want hairs to grow forward if you're going to do the hairline lowering surgery so they can grow through the scar. The patient wants primarily rounding rather than it lowering, as much lowering. They're mainly looking for rounding. Generally, hair transplants are going to be better. Sometimes patients say, I want less surgery. I really don't want anything like the concept of making an incision that could leave a fine line scar. I don't want that. So that's another reason for doing grafting. And also, of course, surgeon experience. There's not a lot of doctors that know how to do hairline lowering surgery, so a lot of times they'll recommend this grafting, which in many cases is the best choice, but I do receive quite a few of my referrals from other hair transplant colleagues who don't offer the hairline lowering surgery, who they feel in certain patients the hairline lowering surgery is better. Anyway, this is another example of grafting, a lot of rounding out, but also some lowering. A lot of rounding out, but also some lowering. These are all examples of hair grafting. A transgender patient who actually underwent prior, not by me, a hairline lowering surgery. Probably at that time they did filing down to the brow bones. This is not an acceptable scar, but anyway, I did grafting not only to conceal the scar, but also to obviously create a more rounded. That's a female to male, a male to female transitioning patient. Let's talk about forehead reduction. It's a 90-minute surgical procedure that advances the entire frontal hairline via a single hairline incision. It's usually done under twilight sedation, which means the patient's breathing on his or her own, but it's done under by an anesthetist in my office. The procedure basically involves the hairline, the forward advancement of the entire hairline, and then we place with these little endotine little hooks into the actual skull, so it secures the hairline at their forward position. It's a 2-layer, what's called trichophytic, which means it gets hairs to grow through the scar. Patients are presentable the very next day after the procedure, and the sutures are removed. 1 week, most of my patients fly in for the surgery the day before. I'll meet with them either usually by webcam, or they'll come and have a consult if they're more local. Then they'll fly in the day before the procedure. They'll have the procedure that morning, and then they can fly home the next day. Stitches get removed back home by either a nurse, a friend, or even some of my doctor colleagues will remove my patients. In fact, for example, I saw that one of my colleagues, Andros he's in Toronto. I just did a webcam on a woman from Toronto early this afternoon. I already told her I have a wonderful facial plastic surgeon that can take her sutures out. So thank you, Andros, in advance. And then you can do hair grafting around 3 months, as soon as 3 months to round out the hairline. My referrals that come from some of my hair transplant colleagues, they'll actually do that grafting after the patient undergoes the hairline lowering surgery. Requirements for candidacy: there must not be any or minimal frontal hairline thinning or nor risk in the future. That's why a lot of men are not good candidates, because they're at risk for experiencing male pattern hair loss. Generally, if a male is under the age of 40, 45, I will not do the procedure unless there's zero family history of hair loss. And of those if they're over the age of 50, then I feel comfortable going ahead and doing it, considering that they're not going to lose that much hair. And even if they do have some hair loss, we can always do some transplants if that scar becomes exposed once the hairline recedes. They need to have good scalp mobility. That's assessed by placing the fingers, and I have patients demonstrate this to me on webcam. They place their fingers right behind the frontal hairline and see how low down they can push it. Typically want a patient that can lower their hairline at least 16 to 17 millimeters, which means that's around 2/3 of an inch. Ideally, I like to do 18 to 20 millimeters or even more, depending on the individual desires as well as the features of the patient. But I explain to patients a minimum, and when I advise them, I say, okay, I anticipate, for example, I'm going to get you down at least 16 to 17 millimeters. However, in 80% of my patients, assuming it's desired, I can exceed that lowering And I'll explain to the patient that that's likely as much as 3 to 4 millimeters, even 5 or 6 millimeters more than the minimum that I've provided them with in terms of expectations. And that's due to several reasons. Number one, when I'm actually in surgery and I'm freeing up the scalp, sometimes it becomes looser. There's also a technique I use that's called galeotomies, where we actually loosen the scalp from beneath. We can do 1 or 2 of these galeotomies and help loosen the scalp so it moves down lower. Also, the primary goal is lowering, not just rounding out. Requirements for candidacy for hairline loan surgery: desire for maximum density and a willingness to accept the fine line scar. Only 30% of my patients wind up getting transplants after the hairline loan surgery, and that's mainly because they want more rounding out, but occasionally a patient wants to have that fine line scar that's a little bit visible to be made not visible. And these are all typical examples: 1 inch before and after. This was around 8 months later. A girl had this done when she graduated from high school. By the time she went to college, 2 months later, she felt comfortable pulling her hair back. The hairs were growing through the scar, and this was after she came back for Christmas after her freshman year. And you can see a typical example. This is what I've marked as the for sure thing, and this is what I've marked as the hopeful. And in this case, sure enough, I was able to achieve the lower line. And you can see also I'm able to round out the hairline with this technique. So it's not just straight across, but it actually comes down. So anyway, these are just some of the basics that's to review. It takes around 90 minutes and it provides immediate results. This is an example of a patient that shows 1 to almost 3, at least 25 millimeters of laxity. So I anticipate bringing a hairline down to here, but actually possibly going down to here. So this is how I have the patient show me how loose their scalp is, how low they can bring it down. And you can see a patient before and after. In this case, I was able to lower this from 9 down to 6.5 centimeters, so around 25 millimeters of lowering. That's a rather impressive result. This is immediately after the procedure. And this is a 6-month result. Once again, the hairline's been rounded out a bit. If we're going to do grafting, it needs to round it out a bit. And another example before and after of just another nice example. And you see how good this density is. You cannot generally achieve this with a single transplant procedure. And a nice procedure for patients of African ethnicity. One of the webcams I did earlier today was on a woman of African ethnicity. She asked the results of African American patients, or African Canadian patients in this case, versus non-African ethnicity. And in general, and I did a study, I'm going to present a little bit of results, that the lowering I can achieve with patients of African ethnicity is a bit more typically than I can achieve with of non-African ethnicity patients. And this is her 1 week after she's here for suture removal. And another before and after, once again, very fine line scar. When this woman came back for some transplants, but you can see how much lower hairline is. And another example of a gentleman I did before and after 1 week for suture removal. That's really impressive. Another guy the very next day after his procedure, before and after, you can see the lowering there. And another case of a gentleman before and after. And occasionally if a patient's got a really loose scalp, a really tight scalp rather, and they strongly want the procedure and they're highly motivated, I'll do what's called balloon expansion. I'll place a balloon placed surgically under the scalp, and then the patient back home will start doing the inflation of the balloon through a tiny external port, doing it 3 times a week over the span of anywhere from 4 weeks to as much as 10 weeks. The scalp will get stretched out, you can see here, and then I'm able to lower the hairline considerably more. It's not for most patients, but it is something that's available. Surgical hairline advancements can also be done if patients have had prior transplants and are unhappy with the density and or of the scarring that resulted because it wasn't done properly, or if they have something called frontofibrosing alopecia. We have started doing it for this indication. Frontofibrosing alopecia is a scarring. It's sort of like a rheumatoid arthritis type of autoimmune process where the body attacks the hair follicles. And I'll show you an example. This is a young woman that had prior transplants, was very unhappy with her results. So I was able to, and this is her in around 3 weeks post-op, I was able to excise all these prior placed transplants, and here they were shaved short, excise them all, and now bring her nice original hairline down lower, so she has a much fuller, more natural look. This pink scar will fade away. This is only, as I said, just several weeks away. This is a gentleman that had a lot of prior plug grafts. We probably have seen these patients here and there. And it's rather than trying to remove all these grafts, we just decided to remove, along with the grafts, all the scarred skin, lowered his hairline. You can see I was able to lower it back to where it was originally with the plug transplants, and you can see the results that I was able to achieve. And this is a case of frontal fibrosing alopecia. This is where you do transplants. It doesn't work. The skin is scarred. The hairline recedes. They also sometimes lose their eyebrows. In this case, I went ahead and just cut out this whole area where the scarring alopecia was, and then lowered her hairline in a single step. In her case, I also did a brow lift, and brow lifts can be combined with these procedures to open up the eyes, and or you can take down some of the frontal bone. And this is, so those are options as well, to do a brow lift to elevate and give a more youthful look. The hairline can be rounded out most commonly with transplants done after the hairline lowering surgery. We usually recommend it be done 3 months later rather than done at the same time. And this is mainly done to round out the hairline, but also can be done to conceal the hairline scar. And you can see this is her after her hairline long surgery, and then grafting was done here to round it out. And another example, this is a woman that came back to me after 3 months, 4 months rather. She had a scar still showed, and this is her after the transplant. So it made her look a lot better. So in conclusion, the hairline advancement lowering surgery provides immediate results. It can lower the hairline by typically 18 to 20, but anywhere from 15 to 30 millimeters or more. It has unsurpassed density. It's equivalent to the transplanting of over 3,000 grafts, maybe even more than that, or 6,000 plus hairs. Quick recovery, sutures removed at 1 week, presentable the very next day, really painless. Most patients have a little bit of soreness that first night. By the very next day, they're able to fly home and look presentable. Hairline scars typically fine line, and the risk of complications can be quite low. So therefore, it's a procedure that should be considered for every patient. So indications for hairline lowering surgery: they've had a lifetime of a high hairline, their male pattern baldness in a transgender patient, and for contraindications if they have progressive hair loss or if they've had prior brow lift. This is a study I presented towards the end of last year in Bangkok. I did a review of 50 patients, actually 64 consecutive patients, just basically to find out their satisfaction, the results, and we had a 78% response rate, which is really quite good. And we asked certain questions. So these are some of the main questions. The average age of patients we did this on was 34 rather. The ethnicity, most were of Caucasian, but we did some African-American and 1 Asian patient. 7 were men, 43 were females. These are the patients that we received responses from. Of those 43 females, 2 were male to female. So 70% of patients had more hairline lowering than what I expected or what I advised them I would achieve. The margin of error is 3 millimeters in predictions, and scalp laxity is the best way to predict how much lowering. This is how many, ignore this is how many of those ghaleotomies or scalp loosenings I did. But bottom line is the average was actually 20.88 millimeters of lowering, and it ranged from 13 to 38 millimeters of lowering. Total, so scalp laxity was a determinant. Patient had excellent scalp laxity. I was able to lower these patients 32 millimeters or more. If they had good scalp laxity, then it was a little bit less. But even those with fair scalp laxity had at least 20 millimeters of lowering. And we, as I said, we got a little bit more lowering typically in patients of African ethnicity than non-African ethnicity. 80% of patients, the hairline remained in the lowered position. In 16%, it moved up a bit higher. So basically in 96% of patients, it basically stayed where it was. In 4% of patients, 2% of patients actually said, basically I think that's 1 patient said it moved quite a bit higher. 1 patient said it moved lower. So maybe we should eliminate those. They sort of balance each other out. Scar appearance satisfaction, we had 72% of patients were very satisfied or extremely satisfied. And if you include these 12%, that's 84% of patients were either satisfied or more with the appearance of the scar. In 78% of patients, the scar was minimally or not at all visible. And then post-op hair transplants, 50% are considering having a hair transplant, while 18% actually underwent. And then the scalp sensation, as I said, there was a little bit of loss in 85% of patients. That the scalp sensation returned as soon as 6 months, and that is not a risk. That's actually just, it's not a complication, it's just a normal risk. And I think this is really nice. Overall satisfaction was was, I had percentages there. Here it is. Overall patient satisfaction was over 85% of patients were extremely or very satisfied. I think that's what it comes out to. But you can see 30 out of 50, you had another 10, so 40 out of 50. So that's 80% were very likely or extremely likely to recommend it to others. Only a very small percentage, I think probably less than 10% of patients were unlikely to recommend that. And I think compared to hair grafting, those results are really not much different. In fact, if anything, that may be superior, because with hair grafting, especially if you're lowering it a lot, many patients require a second procedure to achieve the density that will make them feel satisfied. And unsurpassed density, and bottom line is it's a procedure. It should be considered for every patient who meets the criteria. High level of satisfaction. Here we go, 92% were satisfied, very satisfied, or extremely satisfied, especially after just a single procedure, which is actually superior to that achieved with hairline grafting. So, however, hairline grafting still is a wonderful procedure, and I'm not minimizing at all. I think it's got its definite indications. It's still, I do more hair grafting procedures than I do hairline lowering surgery, but still, they're both excellent procedures, and I think they should be considered for every patient who understands the pros and cons and everything else. So the bottom line is I am able to take your questions. If you have a question you'd like to pose by chat, you can go ahead and do that. If you have a question that you would like to ask verbally, there's not that many patients, there's 32 people, so I can actually click on you, just raise your hand up, or you actually have an ability to raise your hand virtually on your control screen, and then I can choose you. But if you don't have any questions, that's great, but I'm here to answer any questions or whatever else I can answer for you. Yes, Andres, I see. If we're ever able to travel again, I'll come down to what you do on. Andres and I were actually in Switzerland for skiing right before the epidemic really hit the States. We were out of the country in Switzerland. So yes, I will see you. And hopefully, if not to come down to Miami, we can go ahead and at least go skiing. Anyway, another question. By combining a hair transplant with hairline lowering surgery, is it possible to cover a complete Norwood 7? Nowhere near that. The concept behind this procedure is we're only able to lower hairline at most 2 centimeters or so. So really all we're doing is taking patients, we're not talking about addressing the crown or even the mid-scalp. We're talking about patients that just have a high hairline, mostly due to genetics. They were born with it. So this is not applicable for patients with anything more than a class 3 Norwood. That's a classification scheme, a 1 to 7. But no, this is not the role of this procedure. That's a good question. Any other questions? I'm looking through. Do you have a preference of fixation technique? Do you ever do anything other than endotime? I prefer the endotime, those little clips. It is more expensive for me as the surgeon because you have to purchase these. However, I find it's the most reliable. They do dissolve, these little clips, within usually 3 to 4 months. So during those first 3 to 4 months of patients push down, I put 2 of them to hold it out, usually here a little bit maybe closer in towards the center. But I leave the patient. I prefer the endotime. There are other ways. I find this to be the most reliable. Other doctors have described screwing in a little screw, which doesn't get removed. You can come back and remove it. Other doctors rather describe creating these little bone tunnels, these little take a drill and create a little tunnel in the bone. That is another option. Once again, I prefer the endotimes just because they seem to work quite nicely. Another question from Paula. How long after the procedure can I dye my hair again? Patients can dye their hair as soon as 3 weeks later once the incision has largely healed up. Another kind of patients ever experienced scalp hair loss after hairline lowering surgery? That's the major complication you hear about other than the widening of the scar. Every doctor has some cases of hair loss. It's in my hands due to several things. The fact that I don't try to advance it too far, make it too tight. I don't do too many of the valeotomies, and they're done very superficially, so the blood supply gets maintained. and I also am properly choosing my patients, I have a very low percent, less than 10% of my patients experience any degree of hair loss. And those that do, the majority have some temporary shedding right along the frontal hairline. The great majority of my patients, despite what you hear online of these horror stories, the great majority of my patients do not have anything but mild hair loss. And so that's the exception rather than the rule, but it is a risk, but done properly, it's a very low risk. Another question, this is more medically, and I know it was sent to me privately, but is the dissection subperiosteal? Actually, which is basically the level right under the bone. No, the dissection is actually subgaleal. It's a subgaleal dissection. The galea is when you move your scalp back and forth, for those that are less biologically or medically oriented. The galeotomy is that tight layer that connects the frontal forehead muscles with the back of the neck muscles. It's a single layer. On top of it is fat, and then the follicles, and then the skin. That layer is a natural area of mobility. So what we're doing is we're freeing that up by making the dissection, or by doing the section subgaleal rather. And then in the forehead, I'm only going down to around here under the forehead skin, under the frontalis muscle. I'm not going down here because I want the eyebrows to not change in position. And basically, once I move the hairline forward, I secure it in place, and then I can elevate or reposition it and remove the excess forehead skin and secure it in place. And at that time, if a patient wants a brow lift, then I'll go down to their eyebrows and do some mobility. And it is the ideal time to have a brow lift because there's other techniques for brow lifting, but once you have that incision, that's the ideal time to go ahead and dissolve and perform the brow lift. The galeotomy is usually performed around an inch posterior to the hairline incision. I usually do one, occasionally I'll do two, and it's done very superficially. And then I always use a 3-prong endotine. Yes, I use the bigger endotines, not the little ones done for brow lifting, but the bigger ones. Another question. Okay, as an African-American male with hereditary high hairline, but also at risk for male baldness, would I be a candidate? I've been on finasteride to help prevent hair loss. I would discourage you until you're at least 45, 50 years old from undergoing any type of hairline lowering surgery. If you're going to have any kind of lowering, it needs to be done obviously with a surgeon that weighs out the risk of future hair loss. Because even if you're on finasteride, there still is a risk that hair loss will progress. But I would talk with a surgeon you can trust about whether even grafting should be done if you are a younger male at all, and if so, how much, because you want to make sure you don't lower too much. Because remember, once this hairline is created, if you're 26, say, we create a hairline that an average 26-year-old has, and then as you get older and you lose more hair, that would be a real problem in terms of you losing more hair and running out of donor hairs, because there is a fixed or finite supply of donor hairs. So generally, I think that needs to be handled individually, but I would definitely make sure you strongly weigh out the pros and cons of doing this. When I'm doing a question, do I put endotines like I do for a brow lift? They're actually done the opposite direction. If when I'm doing a brow lift, for the endoscopic brow lift, the endotines are this way, so the hooks are this way, so it holds the eyebrows up. In this case, the endotines are placed this way, so the hooks are holding the scalp from slipping backwards. Do you do galeotomy sharply or with a bovie, that's a surgical technique? Absolutely, it's done with a sharp blade and done very superficially. That's the finest portion of the procedure. You do galeotomy, you're going to be zapping all those vessels immediately superficial to the galeotomy, and you basically created a situation where you're at high risk for having some blood supply issues and having not maybe hair loss, but also even some loss of skin. Next question. In the first few days of recovery, do you prescribe medication like Percocet or over-the-counter pain medications enough to handle the pain? We do prescribe not Percocets, but something called hydrocodone or Lortab. I would say probably 70% of my patients take a pain pill the first day or two, but after that, typically just Advil and or Tylenol. But we are prepared to give patients whatever anesthesia they need, or rather analgesics or pain medicines. However, we do inject at the end of the surgery a long-acting anesthetic that lasts for around 8 hours. So that really helps the patient. Maybe later on that evening, they'll get a little bit sore. Do you have any videos online of my surgical technique? I don't put them online because I prefer not to show anything too graphic. However, I am able to share those with you. So if you'd like to go ahead and just email me, I'm happy to abide by that request. How soon can a brow lift be done after surgical hairline advancement? I mean, technically it can be done a couple of weeks later, but it should be done at the same time. If you're thinking about having a brow lift, that's the ideal time to have it done at the same time as the hairline lowering surgery, the actual surgery. However, after the hairline lowering surgery is done, and at some point down the road you want a brow lift, that's not a problem. Also, brow lifts can be done after hair transplants. Can you do hairline lowering surgery, then do grafting if need be? How long between the procedures? Yes, in fact, if we're going to do grafting, it can be done as soon as 6 weeks after, as soon as 3 months after the hairline lowering surgery. Please discuss again about FFA, or frontal fibrosing alopecia, as well as the follow-up of the patient. Frontal fibrosing alopecia is an autoimmune disease, most believed to be autoimmune disease, basically where the body starts attacking the hair follicles, and it proceeds in a regressive fashion. It starts usually at the eyebrows, most commonly in women in their 40s and 50s, but it can happen in some men and women in younger, older categories. It starts in the eyebrows. Around 80% of the time, the patients first lose their eyebrows. Then it starts basically receding the frontal hairline. What you need to be on is first to be properly evaluated, then properly treated to control it. Typically, after it's been controlled for at least a year, we will then proceed with, if the patient's interested and motivated, doing hairline lowering surgery, understanding that this is still somewhat of an experimental protocol we're developing, because we don't know if down the road the patient may still at some point start developing that frontal fibrosis again. In terms of follow-up, we see patients the first post-op day if they want to come in. We usually put a dressing on, like a wraparound dressing, right after the procedure. Patient can remove it the very next day and fly home. Quite frankly, some patients have actually taken off later that day and then fly home. They just wear their hair forward. They can start washing their hair normally on the 3rd or 4th day. Antibiotics are given to them for the first 3 or 4 days as well. Stitches get removed a week later. The hair should start growing through the scar at around 10 days, 2 weeks. Does raising eyebrows remove significant bagging on upper eyelids? No. Raising eyebrows or a brow lift will take care of sagging or drooping eyebrows and potentially softening out forehead wrinkles, but it will not remove excess fat that needs to be done as a separate procedure, which can be done at the same time. Doctor, in your experience, with grafts are usually preferred than SHA. It's very different. I think it depends on the patient's goals, depends on the patient's how they're presenting, and it depends on, those are the 2 major factors. So I discuss with every patient their options. In general, a patient comes to me, a woman, high hairline, born with it, no history of hair loss. Their mom has a high hairline. They've got good scalp mobility. They're looking for lowering and maybe some rounding out. Those are, in my opinion, the ideal candidates for hairline lowering surgery. Patient comes in, tight scalp, no way I'm going to do grafting. Patient comes in, I'm really just concerned about rounding it out. I'm really happy with the location of my center point or my widow's peak. Grafting is the way to go. How soon can one wear tight hair extensions after hairline advancement surgery? I think probably as soon as a couple of weeks later. Just understand that if it's quite tight, they are at risk for developing traction alopecia, which obviously would be a pity after undergoing the surgery. What is the 8-hour anesthetic? Basing on the name of it, it's a long-term Marcaine. It's lipophilic. And I'm sure someone's going to write the name of it. I'm spacing on the name of it. It's also used for like hernia surgeries because it provides long-acting anesthesia. Do you spread your goniotomies to widen as needed? Absolutely. We pull, and I didn't really explain the surgery, but we really crank the patient's scalp forward in surgery, and then not just before we do the goniotomies, after I've done the undermining or loosening them up, but then after I make each goniotomy or the goniotomy, I'll pull as far forward as I can. Is the surgical hairline advancement scar more obvious on African-American patients 3 months post-surgery? Not at all. In fact, if anything, actually some of the African-American patients, when the scar is visible, it's usually because it lightens a bit. But I find that there's no difference in scarring in any of my patients. It's just the occasional patient just has not as good scarring. It has nothing to do with how you typically heal from body surgery, Or even if I've had patients tell me they develop hyperpigmented acne scars, yet this is not an issue. So there's really no way to perfectly predict it, but I will, just having been in doing this, doing facial plastic surgery for over 28 years, I have a pretty good idea. I can advise patients, what their general risk of scarring is. Next question. Exparel. Thank you, Annika. Yes, Exparel is the long-acting anesthetic. It's called Exparel. What is the density of hair grafting? We typically can get around 30 to 40, around 50 maybe hairs per centimeter squared with one procedure, maybe a little bit more if a patient's got really good density. The density that, if a patient's got a reasonably dense scalp, that density is going to be more like around 80 to 100 hairs per centimeter squared. So it's definitely better with hairline lowering surgery. Someone asked if you just have drooping eyelids, as opposed to the other person asked about, can you take out will the fat be resolved? If a patient has just drooping eyelids, drooping eyebrows, and doing an elevation, sometimes that will alleviate or improve the appearance of the upper lids as well. Probably 30% of the time, that's all the patient needs. Around 60% of the 50% of the time, they just need an upper lid blepharoplasty, not a brow lift, and maybe 15-20% of the time they need both. And it all depends. It's an individual issue with each patient. Next question. Any other questions being sent on chat? I'm just going through. Tuna messages. If you do lowering and a brow lift, yes, those can be done at the same time. I believe that was the last question. So anyway, I hope you all found this worthwhile. I do apologize once again for having to mute you. However, it was done because I can't have 30 plus people, or 29 in this case right now, talking. It's hard to control, especially if it's me just alone, or sometimes people have a blender or in the background or a dog barking. So anyway, it's been a pleasure. Oh yes, are all patients' results from one procedure only? With the grafting, yeah. With the hairline lowering, yes. With the grafting, 2 of the 5 were of 2 procedures. The rest were of just grafting. But all those other patients were just of a single procedure. So anyway, I wish everyone a nice weekend. Enjoy these days. I think weekends will sort of blend in with weekdays, but try to make it a little extra special. Enjoy your family, your friends, yourself. Stay healthy, your dogs. It's been a pleasure. I want to thank everyone for participating. And please, if you have any questions, feel free to email us. But once again, thank you to all my friends. Thank you to some of my past patients, some of my potentially future patients, my doctor colleagues, and everyone else who just is curious. Anyway, have a good evening, and thank you once again. This is Jeff Epstein. Bye.